Hello everyone and welcome to today's webinar by Douglas Laboratories. My name is Christy Belalovic and I will be your moderator today. Today's topic is women's health and hormone-specific formulations, personalized care for PMS, PMDD, PCOS, and menopause. Dr. Collins will be discussing these topics today, and we're really excited to have him here as he's presented before on the topic of hormone-specific formulations. Dr. Collins is the author of Discover Your Menopause Type, the first book to define variants of menopause based on different hormonal profiles. Dr. Collins is an internationally recognized leader in the field of functional endocrinology. He is an experienced medical educator and presents many lectures to physicians, pharmacists, nurse practitioners, and other healthcare professionals on diagnostic and therapeutic applications within the functional medicine model. Dr. Joseph Collins is licensed by the state of Washington as a primary healthcare naturopathic physician. He is a graduate of National College of Naturopathic Medicine in Portland, Oregon. Dr. Collins' protocols are available on his website, yourhormones.com, for healthcare professionals who use natural and integrative therapies. His customized therapies include a focus on functional medicine as primary approach to menopause, andropause, adrenal fatigue, thyroid dysfunction, insulin resistance, and fatigue disorders. And as a reminder, Dr. Collins will be answering questions at the end of the webinar, and you can submit your questions in the Go-To toolbar anytime during the presentation. You can also download a copy of the slides at douglaslabs.com. So I would now like to turn the presentation over to Dr. Collins.
Thank you, Christy. It's an honor to be here. You know, we're looking at quite a bit of topic to discuss here. We're going to be talking about PMS, PMDD, PCOS, and PCO-like syndrome, as well as the menopause. That will include perimenopause, menopause, and postmenopause. And then we're also going to probably mention a little bit about adrenarche. For those of you who haven't heard that term, we'll introduce that and discuss that as well. So how are we going to discuss all this within such a short period of time? Well, one way we're going to be doing that is we're going to be looking at the fact that all these different hormone conditions have similarities in them, what I will call like comparable variations. And we're also going to talk about some of the observations that there's a constancy of endocrine predisposition that actually runs through a person's entire lifetime, and some of this is actually starting to show itself in peer-reviewed literature. So I'll share with you a couple of things from literature. I'll share with you some of my examples of what I've seen, and I think a lot of you are going to kind of go, yeah, I kind of already noticed that, because those of you who see patients for long periods of time, you'll notice that the women that have a menopause type that has a low testosterone, when you sit and interview them long enough, they'll let you know they've had problems with low testosterone their entire life. We're going to actually discuss how some of those things actually go back before puberty. So, and we will discuss some of these parts individually, but we're going to discuss them kind of collectively at the same time. So the key words today is probably going to be like constancy throughout life, and also comparable, how these conditions are, those different, they're more similar than we would care to believe. Next page. Okay. All right, there's my bio. She gave you a nice bio on me already there, and if you can review that. As Christy mentioned, handouts are available to you for future reference. In this webinar, we're going to differentiate between the variations of PMS and PMDD. We're going to discuss different models of trying to define PMS and PMDD, about a few different models. We're going to determine the varying clinical manifestations of PCOS and PCO-like syndrome, which is actually a little bit different than PCOS, or it's a subtype of that. We're going to discuss the variant physiology and clinical manifestations of each menopause type. Those of you familiar with my work know that we discussed that a number of years ago first. And then we're going to see how they all have these comparable variations, and more importantly, how do you give individualized care to each woman? How do you find out where woman is, where woman has been, where she will be, and how you can improve the quality of her life by looking at her past, present, and future collectively, making decisions now that will change things. So PMS, PMDD, as you know, is premenstrual dysphoric disorder. PCOS and PCO-like syndrome and then the 3 different variants of menopause. The question we want to ask ourselves is, what do these conditions really have in common? I already said that we're going to be talking about them individually but also collectively. So how can we do that? What do these conditions have in common that we can actually say they have something in common? One of the things that I've observed and the clinicians have observed is in each of these conditions we see pictures of estrogen deficiency, progesterone deficiency, or testosterone deficiency. We also can see variations where they can have very poor estrogen detoxification, where they have pro-inflammatory estrogens in the body. We also see a variant of androgen excess in each of these conditions. And you need to notice that there's an increased risk for adrenal dysfunction and or hypothyroidism. One of the most interesting things I've observed is when I saw I've been doing saliva testing for menopause for decades, and I had a test, we used to call it the Menopause Type test, and we did 3 samples and did the Menopause Type questionnaire. I was surprised about a decade or so ago when I started to notice that younger and younger women were taking it, and they're filling it out, and we're having people in their 20s and 30s complain of hot flashes, night sweats, vaginal dryness, and I told my wife, well, call them, see if they put down the wrong date of birth or something. It was like, I didn't understand that. But then I was interviewing patients individually coming to with the same symptoms. And I remember saying to one patient, she was in her mid-20s, she goes, well, can people my age actually have hot flashes? And I kind of remember that, well, in the old days, they used to call it having the vapors. Remember that, the old English movies? You know, we have some vasomotor at a young age, and we tested her, and yes, she has some estrogen deficiency. So even in their very young age, we can see that, and that could also determine what type of PMS and PMDD she's going to have. So that's some of the variations that are almost universal in all these conditions. So when we talk about the hormones estrogen, progesterone, testosterone, that's the first commonality that they have. An interesting case I had about 2005, I don't think I'll forget this, is a 55-year-old woman who had called me on the phone at the laboratory I was working at, and she did not agree with the low progesterone levels. And as you can see, she had low progesterone levels. She was low end of estradiol, low end of testosterone, even though they were both within their normal range. They were kind of hovering to the low end. And then she goes on to tell me everyone's being told they need progesterone. And as many of you recall, in the 1990s and early 2000s, it was kind of like within all of human suffering can be relieved with progesterone cream, etc. Let's be honest, it got a little overboard there, okay? And she was kind of sensing that. Everyone's being told they need progesterone. I don't need progesterone, your lab's wrong, etc., etc. And I said, well, of course, we'll do the lab test over if you'd like, ma'am, but let me ask you a few questions first. She goes, yeah. So in my interview with her, I said, well, have you had a PMS history? She goes, I had horrible PMS symptoms my entire life. Well, what kind of symptoms did you have? Well, the usual: anxiety, tension, cramps, back pain, painful periods, etc. Interesting side note, those are actually symptoms that were now recognized and associated with low progesterone. Symptoms that are associated with low estrogen or low testosterone are actually a little bit different. We'll get to that in the future. And then I talked about her ability to reproduce, her fecundity. And so I said, well, how did you, with children? She goes, well, I had a couple of miscarriages, and this is true. I didn't make this up. She goes, 3 healthy pregnancies because the doctor gave me progesterone shots. So I kind of paused and waited a second. I said, well, it kind of appears you've had progesterone problems your entire life. What do you think? And she paused a little longer than I did, and she goes, okay, I see that now. Thank you for your time. This is one of many cases that I see, and I'm sure many of you are seeing, in which a woman, when she goes through perimenopause, menopause, the intensity of the hormone predisposition that she has becomes more profound, but the reality is she's had low progesterone her entire life. Now, unfortunately, if we could, it would be nice if we could have gone back 20, 30 years when she had the horrible PMS and said, to be quite honest, the PMS symptoms you have are not usual, because guess what? Not every woman has PMS. It's not some women don't have, the tremendous cramping and tension, all those symptoms. But your symptoms are because you have low progesterone. And by the way, you're probably going to have miscarriages, and when you go through menopause, your progesterone is going to get low. we can't go back in time, but looking back now, we see that picture very clearly. So I start to go, well, this is very interesting. And I also observed a very strong predisposition, a very strong constancy of hormonal imbalances in another specific group, and that was with the PCOS group. So what I did is I started looking in the literature, and I found some very interesting stuff that was a real eye-opener. This is one of many articles. Now I want to share with you on these handouts that you're going to get. You'll see the little hyperlink in the lower right-hand corner here. That's actually a PubMed number, and as you can see when I put my mouse over it, hyperlink pops up. That hyperlink is still active in the PDF forms that you have. So I encourage you to go to these papers. I tried to pick a number of full-text papers if I could, and read them yourself, and you'll be amazed at the amount of stuff that's out there. What they found is that premature adrenarche, which is basically looking like puberty before the age of 8, is not really a benign condition. And these women, these children, I should say, have already started to show early manifestations of hyperlipidemia, hyperinsulinemia, and they look like they're heading towards PCOS. These metabolic abnormalities of PCOS are starting very early in life, and these increase the risk for disease for later on in life. Basically, premature adrenarche, when an 8-year-old girl starts to have the phenotype changes where, her abdomen gets a little fuller, she starts to get some distribution of fat, around the neck, around the back of the neck, and she starts to all of a sudden, why do I need to wear deodorant now, mommy, and this type of stuff, what we're looking at here is where the local pediatrician I talked to, she says, they look like miniature PCOS people, ladies, They have all those pictures, and they have the androgen excess. Now, at that young age, the androgen excess comes from the adrenal glands, but we know then that it winds up coming from the ovaries as well. And basically, is this their destiny? It's their predisposition. It's the risk for later in life. But if we look at these young children now and say, you're predisposed towards androgen excess, we need aggressive management of this before you wind up with diabetes by the time you're in your 30s, which we're starting to see in some of these PCOS patients. We can really change healthcare in this country. Premature adrenarche in PCOS is not a singular observation. I just threw a bunch of other references on here, mostly because I like the titles, but you're going to find dozens and dozens of articles of research. Premature adrenarche, least supply cystic ovary syndrome, long-term consequences. Premature adrenarche, normal variant or forerunner of adult disease. Clinical spectrum of the adrenarche leads to metabolic syndrome. That's back when we used to call it metabolic syndrome. And ovarian hyperandrogenism. There's one that actually talks about premature adrenarche and syndrome X, the old term we used to use. Precocious puberty and the development of androgen excess. On and on and on, paper after paper telling us that at 8 years of age, I can tell you what that woman's going to have, what type of PMS she's going to have, her fertility struggles she's going to have during her reproductive years, and I can tell you that when she gets into menopause, she's going to have menopause type 3, 6, 9, or 12. She'll have one of those menopause types with androgen excess. This is based upon, some of the reasons doing patient histories. We have a tremendous opportunity to make some changes on this, though. Now, another variation of PCOS I mentioned earlier I want to make sure I clarify is, and you'll see this in the literature as well, just type inside the phrase PCO-like syndrome or PCO-like syndrome. PCOS has a specific phenotype, the abdominal obesity, the significant hirsutism and acne, the thick neck, the fat pattern in the upper back. But the PCO-like syndrome has a very non-classic phenotype. These young women, some of them are svelte. They look like they can be models, okay? Their acne's under control. Their hirsutism is so small they don't have their beard shaved like you see in some of the bad PCOS patients. They're not obese and they don't have fat redistribution. If you look at them, they have no sign of PCOS except they have to pay a little extra attention to some of the acne, maybe get a little bit of hirsutism taken. But biochemically and histologically, they are full PCOS patients. Again, about a decade ago, a young woman approached me and she was frustrated because she says she has horrible PMS, etc., and everything's bad. And she went and had her ovaries. She had a scan done, and she said, I had multiple cysts on my ovaries, but the doctor said I'm not polycystic. I said, so multiple cysts, but you're not polycystic, huh? Anyway, so the thing is, and it's because we need to expand our consciousness. Just because she doesn't walk in with a thick, hairy neck doesn't mean she's not PCOS. And I'm seeing a lot more of the PCO-like syndrome as well now. Now, one of those may be because we have greater survivability in neonatology. There's a number of papers that are telling us that children that are born, girls that are born of low birth weight or have had a difficult pregnancy a few weeks early, unfortunately there's a statistical increased probability that they'll have a PCO-like syndrome. And I've seen a number of these, and that's why I like to interview the moms. Not everyone is premature, with PCOS, but then I've found that some of these women that have had the low birth weight, they don't have the classic phenotype. They have the non-classic phenotype, just a little bit of acne, thin body type, but full-blown androgen levels above reference range, and multiple cysts. So the thing that's common in both these variations is they both have androgen excess. They both have adrenal and of ovarian origin, but I think more attention needs to be paid to the non-classical type, because those are the ones that are still being pushed through the cracks, and we're not recognizing them much anymore. Some of the additional dysfunctions, and I'm talking about metabolic variants, obviously, that we see in PCOS, besides androgen excess, obviously, is things I've mentioned already, acne, but also is increased incidence of aggression and behavioral disorders. Alopecia is a common problem. A lot of this is review, I understand. Cancer risk, hirsutism, hyperlipidemia, hypoprogesteronemia. So when you talk about variations of PCOS, that's an interesting thing. Not every one of them has low progesterone, but I'd say at least half of them do. I've tested these women and I've observed them, and many of them are not making enough progesterone. There's some going on with the adrenal glands. They're shunting towards androgen production away from progesterone production. And we see similar types of abnormal androgen shift in certain other conditions, like, for instance, some hyperactivity behavioral disorders, especially in young boys. They'll wind up with excessive androgen.
Dr. Collins, I think we lost you. Are you there?
Hypothyroidism is not universal, but statistically a lot more frequent. Inflammation is pretty much universal. The body is not designed to have all this excessive androgens, and inflammation seems to be a very common problem. Insulin resistance, prediabetes, and full-blown diabetes is very high risk in this population. And one of the in fact, a couple of papers are saying that one of the things you can do is, if you're ever wondering, ask if there's diabetes in the family, because pretty much if someone has PCOS, then either they or someone in the family will have diabetes, and I've seen that to be evident in a number of cases. Tremendous amount of oxidative stress, so obviously all the antioxidants we can do to help these people, and even though we're not going to be talking about obstetrics and stuff like that during this talk, there's a high incidence of preeclampsia in this population. On my website, I have all these listed up, but more importantly, I have some really good references there for you to review and also use as an educational guide for your patients. Some of them don't understand why, they come in for hirsutism and acne, and you're sitting there worrying about diabetes and hypertension, because you're worried about, well, I'm trying to keep you alive, So it's good to let them know that I know cosmetic things are why they come to us, but they need to understand that you and I are also interested in, long life. Now, we'll be going back and forth between different conditions. I'm just going to jump to the thing right here on menopause. Many of you know that years ago I wrote a book called What's Your Menopause Type? It was republished as Discover Your Menopause Type in 2002. And it was basically pointing out the fact that there's a that menopause shows up as transition in many, many different ways, and there's actually 12 major menopause types. The reality is I was going to call them archetypes, but publishers said most people don't know what that is, so we got stuck with calling them types, because in reality there's even variations within this, as many of you already know. Treat each woman according to a menopause type. This was an interesting observation at my time, and it came because, the same thing. I started to see similar patterns of presentation and similar hormone patterns, and I started to go, why are we treating everyone the same? Why do we have one-size-fits-all, pills for them? I mean, one of the mistakes in mainstream medicine is any woman of a certain age who walks the door and she was given Prempro, And then I looked into the natural realm, and everyone was given one herbal pill that had every herb you could imagine in it to fix estrogen, progesterone, testosterone. It was just like, I used to call it herbal Prempro. Lost a few friends apparently by using that phrase. But anyway, the thing is you want to customize, give a woman what she needs. And not everyone has androgen excess, not everyone's progesterone deficiency, etc. The graphic that many of you have seen in the book and some website is real good, and I show this to patients, and it helps people understand real quick here. On the y-axis, to the left there, you can see that a woman can have adequate amounts of both estrogen and progesterone, or she could have estrogen, progesterone deficiency, either one of those, or both. Across the top, normal, low, or high testosterone. Now, what's interesting is when we first started talking about this back in the mid-90s, high testosterone was like barely being discussed. I mean, even low testosterone was barely being discussed. Do you remember when all of a sudden someone woke up and said, oh, women have testosterone too? It wasn't too long ago that all we tested was estradiol and progesterone. In fact, one of the first labs I worked at years ago, all they measured was estrogen and progesterone, and I had to call them and say, can you do a testosterone as well? Well, why? It's a woman. Never mind. So anyway, things have changed since then. Now we understand that, but that was in the early 90s when even the cutting-edge laboratories weren't recognized testosterone. Here we are now. We know we've been there, done that, but this is how much has changed, and we see tremendous variations of menopause. Now, one thing that's important to understand, though, is that this menopause type has been nascent, has been dormant, has been there that person's entire life. I mean, a PCOS patient will start to manifest with adrenarche through puberty, through fecundity, perimenopause, menopause, and postmenopause. So again, the main thing to keep in mind through all this is the constancy of endocrine predisposition that we're going to try to help these women through. Now, when I mentioned the lab tests, I want to kind of go over that, and then a couple points about diagnostic testing properly, because I know a number of you use it and a number of people consult with me on that. Of interest, as I said, this lab test used to be called Menopause Type, but when I started to have 20-year-olds buy it, we decided to change the name to Female Hormone Profile. One of the most interesting features of it is it does 3 different samples, and other things that are important. Yes, we use questionnaires, we do anthropometric analysis and correlation analysis, and I'll explain those to you here. But I want to share with you why it's important to do multiple sample assessment in a moment here, because of some of what the research has been telling us since like the 70s. But before that, I think correlation analysis is a very good way to discuss now. One of the first things we observe, I'm sure you've seen this, I've seen it, is you get a lab test back. And across the top you have the objective lab signs, and we're going to say, oh, you're menopause type 3 or something like that, okay, which basically means you have, high testosterone. Or let's pick, something like that, but everything else is fine. But then you do the symptoms, and she has no symptoms whatsoever. On the other hand, you check her symptoms, and her symptoms are like horrific. She's like menopause type 11. Now, menopause type 11 means she has no estrogen, no progesterone, no testosterone. And you get a lab test back, and you're going, well, how can this be? She has all these symptoms, but she has estrogen, progesterone, testosterone levels, all that are within the normal reference range. Okay, now what we're dealing with here is we're dealing with the difference between hormone levels and tissue response. And we're going to talk about receptor function and co-activators and why herbs work better, stuff like this. The reality is, I think you already know this, our cells never listen to only hormones. They are being subjected to countless molecules and signals at the same time, and many of those signals are being called co-activators. There's actually some called co-inhibitors, the things that kind of decide how a cell is going to react. So for us to assume that we can guarantee how a tissue is going to respond by us measuring 1 or 2 or 3 hormones, it gives us a good idea, but if we don't see they correlate, we need to ask ourselves other things. We all are familiar with the term insulin resistance. We now understand you can have estrogen, progesterone, testosterone, thyroid, DHA, cortisol resistance. And so those are some of the reasons why, even though our patients' hormones are good, they just feel miserable. And this is why we use herbs to act as hormone mimetics and hormone co-activators. We'll be discussing that in just a second as well. Let's see what the next slide says. I get them all over the place here. Okay. Oh yeah, this is talk about require multiple samples. I'm just going to be quick with these and let you all review them at your own time. I think you'll be fascinated. Diane Riad, Fahmy, Reed, and Walker, these 3 must have published like close to 50 papers over a period of decades on saliva testing. These were the pioneers of saliva testing starting back in the 70s. It did not start in the United States. They were doing clinical saliva testing long before we knew how to spell saliva over here. Okay? But this is interesting. What they said in 1980, current assessment of endocrine function requires multiple sampling. Saliva studies have the advantage of ease of repetition. So they said right then and there, a single sample is worthless. If you get the full paper, read the text, they kind of go through that point a couple of times. And then 2009, a different author said that diagnostic value of saliva jump down testing is comprised by rapid fluctuations. And he also says multiple samples are required to obtain reliable information. Okay, and he goes as far as to say we shouldn't even do saliva testing. Well, I go, well, why don't we just collect multiple samples like you just said? Then we can get valuable results. And so that's what we're doing now, obviously. This is a paper going all the way back to 1978 in which they actually compared salivary cortisol, over here, we can see my mouse is the taller of the 2 pictures, to plasma cortisol. And they were actually, it was interesting, they actually compared normal subjects to people with adrenal atrophy. Those little numbers you see down the bottom, those are the ones that come to us, the ones that have like no adrenal function. And then they also tested women that were taking estrogen contraceptives, which as you can see can cause hyperstimulation of the adrenal gland, etc. What's interesting is, again, they did 46 papers in saliva, and all of them discussed multiple sample collection. And then one last paper, I think, if we're going to talk about hormones, we're going to talk about everything, not just the herbs and ways to treat them and how to differentiate the variations, but also how to, if you're going to differentiate variations, you want to know how to test them properly. And then another paper that came out in 2011, this is one of many, that used the phrase day-to-day variation of cortisol. And what they're talking about is that if I test your cortisol tonight and then tomorrow night and the next night, I can see significant variation if you have different pathologies. Now, most people in a state of constancy of health, you will see, day-to-day very low variation, I think like 30% variation in a healthy population. But this paper pointed out that when you start to see, tomorrow's is like 104% and different than, we're basically dealing with a pathology that is either not identified yet or is already known. Anyway, interesting stuff here. So saliva testing is good. You want multiple samples is the key note here. One thing that my patients often ask me, though, is why can't I just do blood tests? And I go, why do you want to do blood tests? Well, because my insurance covers it. Let's be honest. That's a good reason, okay? And then they say, is blood tests good? And I say, well, yes, because the reality is serum hormone tests are the gold standard against which we, and by we I mean us laboratories that work with this technology years ago, as some of you know my background, would measure it against. We'd take blood tests, would plot graphs and go, hey, look, we get the same curve as they do in blood, just like they got a similar curve in the cortisol, more pronounced in saliva, but a similar curve as we look at here, okay? In fact, though, when I had my book convert, it was during the, it went to press in the 99, it was published 2000, the first text. It was really during that time of saliva is, And I brought up the point, I said, well, the thing is, I should have at least mentioned serum's good. And they wanted to turn to payback. I said, I'll only let you turn to payback if you let me add another page, which kind of, tells the truth that serum testing is appropriate if you do SHBG with it. So I do serum testing. I look at estradiol, estrone, progesterone, testosterone, DHA-S in the serum, cortisol, in SHBG and albumin. And as you all know, if the SHBG and albumin are high, then they're going to interfere with primarily testosterone, but also estrogen function. This is important because some people go, well, why do I feel like my testosterone's low? I eat a healthy diet, I eat all types of, whole grains and lots of soy and et cetera, and then the SHBG is through the roof. Or a woman says, why do I feel so bad? I'm on birth control pill that pushed her SHBG, and, so she can't feel testosterone. So do the hormones, we do SHBG, it can really give a profound amount of information and answer questions that these women want answered. Moving to next, we're going to jump something here to PMS and PMDD. PMS and PMDD is one of those conditions that has like this plethora of symptoms that can apply to it, and they can be varied from individual to individual. Some women feel depressed, some have anxiety, tension, and agitation. Other ones are just weeping and tearful, and other ones are like, very dangerous to be around. They get very agitated, okay? We see problems with cognitive function. We see differences between overeating and not eating, insomnia versus, excess sleepiness, on and on and on, tremendous variations. None of these are universal, though, we've kind of noticed. That has PMS has all these symptoms, and there's partly a reason for that is because I think many of you know that there's a lot of discussion about different types of PMS. And this whole topic of PMS is really in the literature to try to define it even now and trying to come up with better ways to diagnose and differentiate between it. But an interesting observation is this, is even though it's a common disorder, it's experienced up to 50% of women in reproductive age. Keep in mind it's possibly up to 50%. Not every woman has menopause, well, they all will have menopause, has premenstrual syndrome. Premenstrual syndrome only happens to about, this is a 2012 paper, 50% of the population. So we need to ask ourselves, why is the other 50% not having it? More importantly, why is this 50% having it? What can we do about it? And this is why we want to look at those, what I talked about, those different variations of hormone function to find out if the woman has PMS because she has a relative estrogen, progesterone, testosterone dysfunction. And then we can fix it better. And that's what we're seeing. That's why we started to see the 20 and 30-year-olds doing these tests and find out that they have, yes, some actually do have progesterone deficiency. Some have testosterone deficiency. Even women without PCOS had high testosterone, some had low, etc. You understand the picture here. So the reality is only half the women have it. The other half is because we have not yet identified the unique constancy of their hormonal predisposition. And once we identify their hormonal constancy that's going to be with them for life, we can teach them how to balance that, and we can change the world. Interestingly, the prevalence of PMDD is only 3 to 8%, which is pretty good. I've seen some of these women, they're very, very debilitated, and I'm glad it's that low. But of interest, the PMDD, a lot of them have just more hints of these hormonal imbalances that we've already discussed. Here's one paper, the British Medical Journal, where the International Society for Premenstrual Disorders was trying to publish some criteria to identify diagnostic criteria for menopause, and you can download and read that there. How they classified it is, first of all, they tried to say, well, it's predominantly physical, predominantly psychological, or mixed. Which is kind of interesting. What all we're doing is saying, well, you have physical, psychological, mixed. You're not telling me with etiology yet. Why are you having physical? Why are you having psychological? Why is it mixed? Okay, and I know you and I, the audience, is interested in etiology. Why? Well, you and I know why. If it's a specific hormone, it can cause either physical or psychological and mixed. Let's find what the hormone is, and not to sit here and be all proud of ourselves because we can now classify it as physical, psychological, and mixed. They also talk about the variant PMDD, that it can be because of exacerbations, and it can also have, that's not PMDD, premenstrual disorders, They also tried to classify by, is it exacerbation of an underlying cause? Is it an anovulatory thing going on? Is absent menstruation? Is it progesterone-induced PMD? Basically, someone's been exposed to progesterone, such as a birth control pill, or sometimes I think the article saying post-pregnancy. So they're starting to look at some of those things. But what's interesting is to try to look at some of the different ways they're trying to classify PMS. Here's one of the criteria that they use. They list all the symptoms for diagnosing PMS. And of course what they're saying is they pretty much come around the time of menstrual period, then they go away. And then they classify them, as I said, into physical, psychological, and mixed symptoms. But what's interesting is some other research talking about the PMDD diagnostic criteria. And this one, they have a nice smaller list and some very specific guidelines. What they say is if a woman has these symptoms within a few days during the week prior to menstruation and they begin to remit within a few days after menstruation, they need to have 5 of these symptoms, including one of either 1, 2, 3, or 4. So they need to have one of these major psychological presentations, either very depressed, depressive mood with hopelessness, anxiety with tension, the tearful, weepy, feeling slightly sad type of situation there, or the angry, irritable, increasing interpersonal conflicts, the agitated ones. They need to have one of those as well as at least 5 of these. Decreased interest in work, difficulty in concentration, fatigability, overeating, sleep disorders, feeling out of control, and physical symptoms. In addition, in order to classify patients as PMDD, the disturbance has to interfere with work, school, or usual social activities and relationships with others. So, just having a PMS that can make someone a little bit moody, but if this actually interferes with it, then that's the diagnostic criteria for PMDD now. And it cannot be an exacerbation of another disorder. You can't take someone that has another diagnosed bipolar disorder or mental illness and say, oh, your bipolar seems to get worse during this time of the month, so now we're going to say you have PMDD as well. No, it's just an exacerbation of an underlying condition, which will happen in many mental illnesses around regular PMS even. So and they recommend 2 consecutive monthly symptoms. And I'm working on different charts right now, trying to find the best ones I can use for my patients to use, like an Excel spreadsheet, to quantify them, or I can make it provisionally. So we have another way of monitoring and define PMS types. Another way that many of you have come across is the different 4 types of PMS. Now, this has been credited to Guy Abraham. He's a professor of obstetrics and gynecology about 36 years ago at UCLA. And actually, a lot of his published work was involved with measuring steroid hormones in different biological fluids. He was actually quite the biochemist from what I can gather from reviewing his work. I didn't find any of his published work on the 4 types of PMS. If it's so this is something he may obviously work on the side. If any of you can find that paper, I'd love to see it. Anyway, what was presented here was PMS type A was anxiety, C, craving, H, hyperhydration, and D, depression. So I've been kind of looking at these and going, they kind of look familiar, and then I'm trying to read how different people interpret them. And I came across an interesting point here is that type PMS A is pretty much considered to be low progesterone. And obviously that can be both adrenal and gonadal. And some of those are symptoms that you see with low progesterone. Remember, progesterone is very calming and soothing. It's anti-inflammatory. Low progesterone will cause palpitations, So, so this kind of fits into that picture of low progesterone. The low estrogen was interesting because, you remember I mentioned the young women with that? Well, this is obviously part we're seeing here. Estrogen has lots to do with mood and cognitive function. So they complain of dyscognia and neurological functions not being real good, forgetting quite a bit. So you see a lot of cognitive symptoms here, as well as some depressed mood, because obviously low estrogen has been associated with depression. Excuse me, previous, okay. Low androgens up here, the top one, they call that craving. There's all these hypoglycemia, fainting spells. A lot of these are actually symptoms of either both adrenal or gonadal. This could be the adrenal fatigue or low testosterone can cause some of these symptoms. In fact, headaches is one of the questions I use in measuring the menopause type profile, because low testosterone, when it drops, it can cause more likely to have headaches. Heart palpitations can be caused by low testosterone, headaches, low testosterone. So you see some of these things when testosterone doesn't work properly. This last one here was kind of interesting because hyperhydration, what everyone's talking about is that it's because of this too much aldosterone. And I said, well, it's kind of interesting because it also looks like some of the same symptoms I see: acne, the weight gain, the retention, the nostalgia, breast congestion. I see some of these in these young women that have androgen excess. So I was going, well, how does, but I agree, it does sound like high aldosterone. And I came across some really interesting papers. You can probably find the reference yourself. That increased testosterone raised aldosterone. So now we kind of get to understand what's going on here. So we're looking at the different PMS types because of either low estrogen, progesterone, testosterone, or even high testosterone. And we now understand now that the fluid retention, stuff like that, in all these conditions here are basically associated with androgen excess, which also causes high aldosterone. Which is interesting because you talk to any of these gentlemen that are taking testosterone. I give some of those patients as well, and they always complain that they wind up, retaining fluid and weight gain, all that after they get their testosterone therapy. So, kind of makes sense there as well. So we understand those different types of different variations of hormones as well can cause the different types of PMS. But the next thing we're going to look at is hormone and hormone receptors. I know we talked about these a little while ago. And here's a picture of the hormone estrogen receptor proteins that are paired. Remember, hormone receptors, they don't, even though the previous slide showed them individually, they have to couple together, pair, as I showed you. And then there's the pairing of them that is involved with the receptor. And here's a different graphic here. She's two progesterone estradiol receptors coming together to form a pair, and then they actually merge and they actually interact dynamically with the DNA. And this is how hormones communicate with DNA. The hormone receptors will interact, and then they'll come to the receptor, but they'll pair, as I just mentioned, and then they become cofactors. And then they work with co-activators, and these co-activators help the hormone receptor bind to DNA and help instruct the DNA, etc. So these are things that was really surprising me when I read this thing about co-activators. I want to understand more about that because I said, what's a co-activator? And it talks about some endogenous co-activators, but then I came across it with some plants are actually called co-activators, and they were defined as that way. And so I looked at some of the research, and I realized that all the different plants that we use, they all, to some degree or other, will interact with, here's co-activator proteins here. They affect gene expression. They affect messenger RNA. The previous one, there was some talk about interacting with DNA and all these different receptors and different RNA here again, okay? What's interesting is phytotherapy, herbal therapy has gone way beyond folk medicine to the point now where we're at molecular biology. We can actually look at a plant now and say that this plant actually interacts with the caspase-3 gene, which downregulates the dorsolateral cortex and all these multi-dollar words here and stuff like that. The reality is now we're no longer dealing with folk medicine herbs. We're dealing with plants that actually affect gene expression, which is why these herbs work, is because they interact indirectly with the DNA of our cells. They communicate with them, and they're acting as co-activators. They're assisting with proper hormone function. So how these hormones work more effectively is when you have herbal therapies that act as co-activators, and they can assist to get the message through and stuff like that. It's pretty fascinating. I'm pretty sure that this is some work that is going to be continued in other realms, and maybe someone will sit and compile this exhaustive list. I mean, I just can't believe how much stuff there's out there, but it's pretty fascinating. So that's one of the factors that involves why our bodies not respond to hormones. Remember the slide we showed, correlation analysis, where you can have this lab test but this symptom, and what we recognize is you can actually have agonists or antagonists. You can have co-activators that can be agonists and help the hormone work better, or you can have what they call co-pressors, which we can also call antagonists, which can interfere with hormone function. So it isn't just the hormones. It never has been just the hormones. A big part has been our tissue's response to the hormones, and our tissue's response is heavily influenced by our diet, but it can also be influenced by the herbs that we use. Keep in mind that, you know, in many other cultures, herbs are a regular part of their diet, you know. In America, we use very little of these herbs that are used in other parts of the country now. I often say that when you go into a restaurant and there's herbs and spices in the food, what do you call it? It's called ethnic food, because American food doesn't have spices. Moving away from spices, we just talked about agonists and antagonists, cofactors or co-activators or co-pressors. And this is like a little graph I put up a while back and I share with patients to talk about the level versus response from hormone function. You can have, in the far right-hand side here, you can have high levels of hormones, and you can have resistance because of, you know, hormone resistance, or you can have an antagonist. A good example of that is you can have plenty of testosterone, but if you're taking progesterone, such as medroxyprogesterone acetate, that is a very strong antagonist. It interferes with androgen function. In fact, MPA is used for male sex offenders. So it's definitely not something that should be given in the, oh wait, they do give that to perimenopausal women. Gosh, no wonder why they all have problems with libido and sexual function, etc. Okay, anyway, look over here. You can have low levels of hormones, and the person says, I feel great, and they can do fine. And see, this is why when I deal with patients that have, you know, hormone levels in the low end of normal, instead of always trying to push them up higher so they feel better, I say, let's help your body work better with what you have before we start subjecting it to the possible consequences of exogenous hormone replacement therapy. So what I just lost something. Okay. So what are some of the symptoms of hormone deficiency? These are symptoms that are very well known to all of us. And many of these are actually incorporated inside the Menopause Type questionnaire, the questions I use. I think all of you probably have these somewhere inside one of your intake forms, and we use these to quantify the number of symptoms that a person has that kind of tell us, you know, what's the likelihood that you have estrogen deficiency. And yes, we can see that at the top we have hot flushes and night sweats, and at the end we have risk for heart disease. So we look at the symptoms that they deal with. We also have to recognize that we're dealing with risk factors as well for diabetes and heart disease, etc. And these, as I said, are very well-known symptoms. The big difference now, though, is these are not just symptoms of perimenopause and menopause. These are symptoms that we're seeing in younger women now, and we need to see how we can help their estrogens work better. Many of them do not need to be put on antidepressants. They need to have their hormones rebalanced. It doesn't always mean giving them hormones. It may mean giving them an herbal supplement that acts as an agonist or a co-activator to help the estrogens work better. The signs and symptoms of suboptimal progesterone function. And you may notice I had that in the previous slide as well. I always like to call it, I don't like to say estrogen deficiency, because these people aren't always estrogen deficient. Sometimes they have estrogen in the normal range. What we're dealing with here is suboptimal estrogen function. The same thing here. Suboptimal progesterone function, you know, generalized fatigue. A big part of that is because 60% of a woman's non-luteal progesterone comes from her adrenal glands, meaning that during the follicular phase, if you measure her progesterone, 60% of that is coming from adrenal glands. So if you see that that's like really low, you go, wow, you're like below half, which means that your adrenal glands aren't even giving this 60%. And you pretty much have an idea of what I'm about to say. Low progesterone is associated with adrenal fatigue. One of the best things we can do to enhance endogenous progesterone function is to enhance adrenal function using adaptogens that are targeted to stimulate progesterone function, production actually, which is what I use obviously. Progesterone is very interesting. It's very calming and soothing and anti-inflammatory. So when the functioning is low, they feel irritable, tension, etc., more aches and pains. They just feel miserable. A lot more allergies and asthma, spasms and cramps, etc. And again, more fatigue. Again, I guess fatigue's all over the place. Breakthrough bleeding, obviously PMS is a big part of this. And, you know, the breast shrinking for some reason got in there twice. The next slide is on signs and symptoms of suboptimal testosterone function. Remember, these people may have testosterone in the reference range. It may be in the 25th percentile, but there's still enough. You don't need to take everyone and push the testosterone into the 90th or 100th percentile, especially if you want to, you know, avoid getting some of the risk of high testosterone in women. So if she has testosterone in the normal range, and is low normal, and she has these symptoms, then we need to enhance the function using, obviously, some of the cofactors. And yes, we understand a lot of the symptoms are focused on sexual function, libido, and orgasm, etc. But also understand that testosterone has to do with cognitive function. Testosterone has to do with maintaining attention, linear processing, doing math, task performance. We have both adult men and women who say, I think I have ADD, I can't concentrate anymore, I can't hold my attention. Well, low testosterone presents as attention deficit disorder because it stops that linear thought processes, again, from point A to point Z. They're easily distracted. So when a perimenopausal or an andropausal person comes to you, it's most likely decreased testosterone function again. And obviously there's a lot of decreased muscle mass, they feel weaker, mood disorders, etc. On and on. So urinary incontinence, obviously, because the periurethral tissue has behind both estrogen and androgen receptors. So that's something to consider also when you see urinary incontinence. Look at androgen deficiency, not just estrogen deficiency. And then the next slide, obviously, is some of the signs and symptoms of excessive testosterone. We've discussed some of these. The hirsutism, body hair, you know, alopecia, the acne, the oily skin, the different mood disorders, increased risk of breast cancer, elevated triglycerides, and cardiovascular disease, etc., sleep disturbances. So, again, those are signs of excessive function. Now, again, I sometimes see a woman that has, quote, normal testosterone, or testosterone in the normal range, but it's in the height of normal, and she's showing these signs of excessive testosterone, and that may still be signs for me to kind of calm down that. She has too much, her body is hypersensitive to her testosterone levels being like in the 80th or 90th percentile. So I may use some anti-androgen therapies and kind of teach about the possible risk. And another thing I'll do sometimes if I see that testosterone is measure androstenedione glucuronide, and that's the an androgen that can be quite elevated. And also you can look at DHEA. It's androstenedione glucuronide, excuse me, that can be elevated in these women. So do like a whole androgen panel if you really have doubts about these patients, and those can be done at any of the major reference laboratories. The signs and symptoms of thyroid would be, I know we're talking primarily about female health disorders, but as I mentioned, one of the things that can manifest in these is secondary or coexistence of low thyroid function. These are some of the many symptoms that are associated, but I make a real point here to say that these symptoms can also be associated with other conditions, so risk assessment is also required. One of the things that's important is you really can't diagnose thyroid disease unless you have a good lab test on it, you know. And of course that means measuring what? Free T3, free T4, reverse T3, and TSH at a bare minimum. You'd be surprised how many times I see people being told they're normal, and then I measure the reverse T3, and it's through the roof. I had a patient recently who was told there's nothing wrong with them, and then the reverse T3 was twice the reference range. And they wonder why the person was doing so bad clinically. It was pretty horrific, actually. So these are the symptoms, but look at the risk. What I put together is, and you can download this questionnaire and use this on the website, is I list all the symptoms, but then I talk about risk factors. And I ask about personal risk, lifestyle risk, family-based risk, and then you compare the risk to symptom ratio. So if you have all these signs and symptoms that we associate with thyroid disease, and then you have no risk, then maybe you should look at either adrenal glands or something else. So look at that. I think you'll find it helpful. Drop me an email if you want to discuss that further. Many of you know we did an extensive study on adrenal health in the past. You can watch the video online. This is a direct link for YouTube, or better yet, go through Douglas Labs and look at not only my video, but a lot of good videos by some pretty excellent speakers that they've pulled together for all of us. So I'm not going to touch on adrenal health. We really went into that intensively at that point in time. So how do we support optimal hormone health? Many of you know that the work I've done is, I don't believe in one size fits all, what I call Prem-Pro. Here's a pill that has everything in it, I think that we need to have an herb that if you have estrogen dysfunction, I want to improve estrogen function or progesterone testosterone. You may need two different pills, but, we're going to get it done right this time, okay? So typically, in other talks, I'd go through each one of these herbs in great detail. You many of you have seen those, but right now I want to do something a little different and show you, like, we're talking big picture here. We're talking about constancy of endocrine dysfunction throughout life. We're talking about similarities. So I want to give you the big picture of each of these formulations and let you grasp that, and then you can find information on Doug's website, on my website, or I can give you more any more information you want. But first of all, these plants are beautiful, aren't they? That's always the nicest thing to see how beautiful they are. And then what I did is I said, okay, what does estrogen do, and what I want to do it without using estrogen, by using plants. So I line up all these plants, and I over the years, I found out which ones will actually give me actions that I want. And so I found specific herbs that can help with that. I missed a couple of dots here. Actually, there's supposed to be X here and here. These two actually help with vasomotor symptoms. Okay. I'll update it. What you're going to find is estrogen has different herbs have different properties. Okay, here we go. All of them have estrogen mimetic properties documented in the literature, where they mimic certain functions of estrogen. Now, some of them have well-documented nootropic or brain function activity. Some of them very strong anti-proliferative, if I can say that word, the C word. In some of these things, especially go to the website Estromen and read up on what I have to say about Centella. Quite a few of them are antioxidant. Some help with libido. They're neuroprotective, cardioprotective. Many of these actually are adaptogens, etc. They all have different properties. Collectively, this formulation is able to remediate all the symptoms of low estrogen in these patients. But an interesting point here is that it also has the ability to increase 2-hydroxylation. As you recall, 2-hydroxylation is that process in which estrone and estradiol either go down this way, and they go this way to the right and become 2-hydroxyestrogens, which are non-carcinogenic compared to the 16 estrogen metabolites, especially 16-alpha-hydroxyestrone. They also don't go over here to the 4-hydroxy, which is just as bad. The most important thing, though, is if you convert them to 2-hydroxys, and then you give your patients lots of B12 and folic acid, you can make the 2-methoxyestrogens, which are literally anti-cancer. 2-methoxyestradiol, study, you'll see it's in literature, are anti-cancer. So this is kind of why I like the formulation. It is very safe and protective, and it also is proactive as far as helping some of these patients. And as you understand, this whole thing about estrogen metabolism is just a very small part of a much bigger picture of the biochemical pathways we need to deal with. So, we still got to make sure we, give them all the nutrition they need, keep the bowels moving, etc. A lot of work to do, but that's one place you can focus on sometimes. The next slide is progesterone. Again, some pretty awesome-looking plants here. The primary goal is to look at plants that have phytoprogesterone-like properties. Phytoprogestogenic. We're actually going to see. I didn't want to find plants that would stimulate estradiol production on the previous formulation. There's enough anxiety on estrogen for me to say, here, take this, it'll make your estrogen go through the roof. Well, no, thank you. I want to use herbs that will mimic estrogen and palliate its symptoms, but not raise estrogen. Now, for progesterone, I want to do a little different. I actually want herbs that will actually have phytoprogestogenic properties that will actually raise progesterone levels. And yes, I still want to mimic some progesterone as well. So this is what we found here, is that some of these herbs have been documented again in the literature to raise progesterone levels. All of them will mimic it. They're shown to mimic specific properties. A lot of good stuff here. Review this at your own time and just see it. It's amazing. We have anti-proliferative actions here, anti-inflammatory. They all have been documented analgesic. Remember, progesterone's calming, soothing, anti-inflammatory. And so I want to use a plant that was calming, soothing, anti-inflammatory. So we have some GABAergic properties. We have some anxiolytic and stress management properties inside here as well. first and foremost, they do mimic progesterone, and they are progesterogenic, and we are seeing progesterone levels become higher. But more importantly, they kind of make people feel better right away. And just as progesterone is anti-proliferative, if we use that word again, these herbs all have anti-proliferative and very protective properties as well. Very exciting. Also some good glycemic control, antioxidant, amazing. So this is one of the goals was to create a product, a formulation that would not only be like an herbal vegetarian substitute for progesterone, but also encourage your body's own production of progesterone, which is what these herbs specifically do. Here's some other interesting, beautiful plants. I don't know if I'm walking through a jungle, if I want to see that jumping out at me. I'm kind of, but it's supposed to be pretty good for you, so I'll put up with it. But these are all some of the plants I use for testosterone. And again, I want phytoandrogens. I also want to try to raise testosterone because I'm not as afraid of that, and I want to mimic testosterone. And that's exactly what we accomplished here again. Of interest, though, most of these plants have documented and they've been labeled as adaptogens. So these are really good for the adrenal glands as well, which obviously makes sense. You know, if your adrenal glands are fried, you're going to have a problem with gonadal function as well. Androgenic properties have been documented. Testosterone production. These plants here have been documented as making progesterone. Making testosterone. Of interest, I've been searching wide and low, and I could not find Leucococcus raise testosterone. Yes, it's a good adaptogen, and it has some other good properties, but it didn't actually raise testosterone according to any literature I could find. A number of these herbs are anabolic. Testosterone stimulates dopamine function, and it's, you know, just like progesterone is GABAergic, estradiol is more like serotonin, testosterone is dopaminergic. So I was really pleased to try and find herbs that also kind of support the dopaminergic properties, especially since dopaminergic properties will lower the prolactin, and as you know, high prolactin can suppress testosterone, so we need to make sure we kind of got that in the mix as well. To be quite honest, we're not trying to jack up the nitric oxide too much. We have some assistance with that, but as you're aware, nitric oxide can also be a bad molecule. Too much nitric oxide can be, you know, neurotoxic, etc. I remember years ago someone was talking about how, you know, all these older gentlemen walk around with the nitric oxide through the roof, winding with dementia. You know, not something we really need right now. So you need to kind of balance it off. So if you're going to do that, you want really good antioxidant protection, which thank goodness we have with most of the plants. And again, there's an anti-proliferative, the protective word there. Strong neurotropic activity. These are very good herbs, help with keeping the mind sharp, which makes sense. We talked about when testosterone is low, what happens? People think they have attention deficit disorder. So I was obviously very pleased that these herbs show neuroprotective and neurotropic activity. Many of them mimic testosterone, and most of them actually have been documented, surprisingly, except for Leucococcus, as increasing sexual desire and improving sexual function. Very interesting thing there. So we have an herb that not only helps the body make testosterone, but helps the testosterone function better. We want both. We want more hormones, and we want them to work better. And then the last thing we'll look at is androgen control. I want phytoanti-androgens to calm down the effects of excessive testosterone. Now what we did here is we used to have something called Test-to-Quench, but we changed this one to be Test-to-Quench for women because this one is more feminizing. It's more going to help more with female problems of androgen excess, like peony or lactoflora is very beneficial, Vitex eggs, all these things. These things are going to be more beneficial to a woman, increasing the amount of trigonal phenoglycine, which is actually feminizing. So they're more like not just anti-androgen, they're more also going to help with some of the other properties as well. This is more of a feminine Test-to-Quench, whereas the Test-to-Quench for men now has been reformulated to be quite aggressive at protecting the prostate, much more than this formulation does. So the women are liking this one. It's still protection from the androgens, but it also has some of the other properties, anti-inflammatory, adaptogenic, helps with the blood sugar problems, anti-proliferative, which is very important because there's a high risk for that, neurocognitive and analgesic. So a little different than the original Test-to-Quench, more of a feminine formulation. So when we looked at this whole thing, what we talked about, what were the two words for the day? Comparable, very variations. Every one of these conditions can have estrogen, progesterone, testosterone deficiency, or androgen excess, detoxification, and risk for these conditions. And there's a constancy of endocrine predisposition. Now, once we identify this constancy, we can and we have been actually making some significant changes in lives. Now we're starting to treat entire families. We have grandma in menopause bring inside her, young adolescent child who basically she has realized and is heading for her same destiny. So we're seeing young teenagers making life decisions now based upon some of the educational things we're doing here. It's pretty exciting, and I hope that you can see the value of this, because I think most of us, have broad enough practices that we see people of all age groups, and we can really help entire populations this way here, okay? One last thing about the formulations is, let's be honest, it's supposed to get better on them, okay? I noticed this. So what I found is many of my patients, well, first of all, a lot of them want to start in a low dose. So I started them on 2 a day for a couple of weeks, and then I started them on 4 for 2 to 4 months. And what we saw was tremendous recovery, tremendous improvement at that dose. And then that conscience, after 2 or 4 months, say, do I still need to take that much? And I'd say, well, apparently not. So we'd lower them down to 2 for maintenance, some down to 1. So all of these formulations now have been reformulated. They now each have 120 capsules, and we're using like a 2-4-2 dosage protocol, and we're seeing some amazing results with them. I've kind of been doing this on my own using the old formulation with the different dosages, but I'm definitely convinced that the 2-4-2 protocol is a really good way to go when you're dealing with very complicated herbal formulations. Get them up to where they want to live, and then wean them down and go to maintenance. That's where they want to live. They want to go out and enjoy their lives and tell their friends about you. Some of you may know some of the previous things I wrote are still on Douglas's website, the Nutri News. They're a few years old. There's a few more herbs I'm using now than then, but you'll still find them very informative with a tremendous amount of references. And don't forget to check out Douglas's YouTube. I mean, quite a bit of really good education on that. Go to the Douglas's YouTube account to get some good information here. And last but most important, stay in touch with me. I'd like to hear some of you share with me your experiences in these concepts of similarity between these different conditions and the constancy that we're seeing from the very young to very old, looking back and saying, oh my goodness, this person has had this hormone problem their entire life, or I talked to this woman's mother and she had the same thing and able to do that. Give me some of your feedback on that. Ask me any questions you have about either the formulations in general or any of the ask me any questions you want about laboratory testing or anything I can do. My company is called Your Hormones, so I guess you can figure out what I like to specialize in. And I appreciate your time. It's always an honor to talk to other healthcare professionals, and I'd really be honored by continued conversation, dialogue, and emails with any of you at your convenience. Thank you very much.
Thank you, Dr. Collins. That was a wonderful presentation. We really appreciate all the hard work you put into this and being available to share all of your protocols, your website with us, as well as your email address. So we have gone over the time limit today. I will take a couple of questions, but I would encourage most of you to email Dr. Collins directly with your questions, since I know that we do have a lot of people on the line today that have a lot of more detailed questions, I think more specific to their patients, that I think would be better directed directly to Dr. Collins. And I just wanted to clarify that the product information, as far as the dosage protocols, are specifically listed on the actual product itself, along with the product data sheets, give you an exact suggested use protocol that can be accessed via our website as well as the yourhormones.com website. So a couple of questions for those of you that can stay on the line. I realize many of you have to go, and that certainly is okay. A copy of this presentation will be available on our website shortly, along with the slides and handouts, again, can be accessed via the douglaslabs.com website. So Dr. Collins, the first question that I want to address is when you mentioned back as far as testing for serum blood levels, you had recommended testing for SHBG. the question is, what is your favorite way to decrease this if the cause is due to low free testosterone?
Oh boy, that's a tough one. Low in SHBG. SHBG, I lower it by finding out what the cause is. Usually the person is either being exposed to some type of estrogen or a dietary estrogen. Sometimes people, to be quite, I hate to say it, but sometimes people eat too much soy, and that pushes the SHB through the roof. So I talk to them about trying to rotate some of the foods out of their diet to avoid the high SHBG. Again, it's treating the cause. SHBG is elevated because of estrogen stimulation. You know, another name for SHBG is capital T, small e, BG, which is used to symbolize that capital T, even though it primarily suppresses testosterone function, small e, it's induced by estrogen, binding globulin. So that was one of the old names for it. We need to find the cause, and most of the time I find it's dietary, and that can be changed.
Okay, great. Thank you. Another question is that there seems to be a prevalence of adult onset acne. Do you know the possible cause of that and any natural treatments that may be available?
Well, I think some of if it's not an androgen excess disorder that we're dealing with, then, of course, I rule that out. First of all, I'm looking at the probiotics. I remember some of the research talking about, and I've been seeing this, where we actually have probiotic over our entire skin of our body in different areas. So I get much more aggressive with probiotics. I'm not going to make suggestions about if anyone want to try this, but there's an interesting paper from Russia in which they did facial washes with probiotics, and it seemed to help you. So I'm old enough to try that. Consider that. But the reality is we have bacteria over our entire face, and so I look at that obviously, and then of course. One thing I tell patients is, inflammation you see is not all the inflammation that you have. So I look for the signs of inflammation and see if what we're dealing with is basically an inflammation that's systemic inflammation is manifesting as acne. And then, of course, I look at the anti-inflammatory diet and, of course, lots of the fish oil and this type of stuff. So obviously look at the androgens first, look at probiotics, look at the anti-inflammatory. Those are going to be the most important things there.
Okay, great. Thank you very much. And when you were discussing, back to labs, when you were discussing that, I think we lost connection with you for just about a minute. So if you could just kind of, that's okay, reiterate for everybody that you believe that a combination of testing serum blood along with saliva is the best way to go. Is that correct?
Well, the way of one of the best ways to there's two options of testing. If you're going to do serum, the serum test requires SHBG to be accurate, because if you just measure like estradiol and progesterone and even testosterone, and you don't measure the SHBG, you don't have the proper scope to view it through, because if SHBG is high, then you'd interpret your serum test completely differently. Now, concerning saliva, the literature going back into the 70s has told us that, because it fluctuates, that's one of the advantages. You want to do multiple samples. So, for instance, I collect at least 3 different days, and then I do, like, on the lab test, actually like a fluctuation analysis, because what we're seeing in that one paper mentioned about cortisol is the more unstable your hormone are, the more likely are you're not really feeling too good. So saliva requires multiple samples, to be done correctly. So you want estradiol, progesterone, testosterone from at least 3 days, and serum requires SHBG. Once we know the limitations of lab tests, then we have tremendous liberty to feel confident in using them in making our diagnoses.
Yes, thank you for clarifying that for us. And one more question was on the Testogain formulation. We talked about that in regards to women, and I just wanted to clarify the Testogain formula can also be used to increase testosterone levels in men. Do you have
yes, absolutely. Yeah, the Testoquench had to be differentiated because of that, but the testosterone deficiency, again, there's a commonality there that you can use the same herbs in both men and women, and we have quite a few men of all ages using and test again, and women can as well. So there's enough commonality in low testosterone function that the test again formula is very efficacious in both raising testosterone function and production in both genders. But you know, we're always looking forward, and we realize that we need to differentiate between the test of quints, which is why Douglas Labs and myself decided to do that, to make it more specialized, for not just the women, but for the men, to protect the prostate on the other formula. But test it again, share it, both men and women.
Yes, thank you. And another question on salivary lab testing. First question is, what lab company do you prefer to use for testing, and what time of the day do you prefer to test for salivary hormone?
Well, there's a lot of good labs out there, first of all. Mostly, the one I personally use is, I use Pharmason through a private contract I have with them. I've used other labs. I've chosen them for the past decade. And then the time of day that it's best to collect estradiol, progesterone, testosterone is the morning, mostly because that's where most of the research has been collecting morning samples. There are a few papers where they collect morning and then afternoon and evening, mostly for academic stuff. But the gold standard where most people actually measure testosterone, estrogen, progesterone is in the morning, and that would be that person's morning. So if they're a shift worker, they'd have to adjust it to their wake up in the morning type of stuff.
Okay, great, thank you. And I think we're going to wrap up the questions now. And again, if we didn't get to your question, please email Dr. Collins directly. And again, just thank you everybody for attending. And again, thank you, Dr. Collins, for answering our questions and providing such wonderful information. And please look forward, on our website to next month's webinar. And again, a copy of the webinar today, as well as a copy of the slides, will be posted on the douglaslabs.com website under the webinars tab, and that should be up on our website very shortly. So again, thank you everybody for attending, and have a wonderful day.